Good afternoon, everyone. My name is Shelley Bolleton, and I'm the Director for the Centre for Vaccine Preventable Diseases at the University of Toronto. I'm very pleased to welcome you to our webinar this afternoon, which is co-hosted by the CVPD and the Centre for Global Health, which are both at the University of Toronto, and by UNICEF Canada. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. For those of you who are joining from elsewhere in Canada, I invite you to reflect on and acknowledge the land on which you live and work. Transparency in research is key to public trust, so we would like to note that the CVPD is supported by the Dalla School of Public Health at the University of Toronto, which funds infrastructure and faculty and staff salaries through a mix of operational funding, grant funding, and donor funding, including funds from vaccine manufacturers. We have a robust set of governance processes at the CVPD to ensure that funding sources do not impact the academic freedom of our members. For further details about our funding and our governance, please visit our website. So today we are incredibly fortunate to be celebrating National Immunization Awareness Week with two very distinguished guests. Dr. Ephrem Lemango from UNICEF and Dr. Natasha Crowcroft from WHO have joined us, and we'll be speaking about global immunization coverage and access. In this conversation, we are going to celebrate past successes, explore current challenges, and discuss ways to continue improving immunization coverage in a global context. So I will go ahead and introduce our speakers. Dr. Ephrem Lemango is the Associate Director and Chief of Immunization for UNICEF headquarters in New York. He oversees the immunization and vaccines-related work of UNICEF, spanning across 7 regions and over 130 countries. He has previously worked as the Regional Immunization and Primary Healthcare Focal Point at the World Health Organization Regional Office for Africa, where he led interventions to strengthen immunization systems and provided strategic leadership on the development of the vision for the Regional Immunization Agenda 2030. He comes with more than 16 years of progressive national and international experience on immunization, child health, maternal health, primary healthcare, and macroeconomic issues, from which about 11 years were in senior leadership roles. Dr. Lemango has been a guest at CVPD webinars several times, and we're really thrilled to welcome him back. Dr. Natasha Crowcroft is the Senior Technical Advisor for Measles and Rubella at the World Health Organization. With more than 30 years experience in public health and more than a decade of international work on measles and rubella elimination, she was a member of the international expert group that verified elimination of measles and rubella in the regions of the Americas, and also a member of the WHO SAGE group on measles and rubella. She is an adjunct professor at the Dalla School of Public Health, and she was also the inaugural director of the Centre for Vaccine Preventable Diseases, so you can imagine how thrilled we are to have her speak today. So just a few short housekeeping items before we kick off. After our presentations, we are going to have a question and answer period where our panelists will be happy to take your questions. The Q&A pod at the bottom of the screen will be open throughout the webinar, so please type your questions or comments there, and we'll answer them during the Q&A period. We will do our best to get to as many questions as we can, but please reach out to us at cvpd.dlsph@utoronto.ca with further questions after the webinar ends. We're pleased to let you know that today's webinar has been approved as an education credit offering through the Certification Board of Infection Control and Epidemiology. So we're pleased to offer one infection prevention unit, or IPU, for those who attend today. So please email us once again at cvpd.dlsph@utoronto.ca after the webinar for your certificate. Lastly, we recognize the value of reasoned discourse, and this commitment comes with the responsibility to ensure respect for others. So please ensure that any questions or comments for today's speakers are made respectfully and remain in the spirit of positive discussion. And with that, I will turn it over to Ephrem, who is our first speaker.
Good morning, good afternoon, everyone, wherever you are, and good evening, colleagues. Can you hear me okay? Perfect. It's always great to be here. It's, I think, my third or fourth time speaking on this platform, and it's always inspiring and leads to much rich conversation. So I'm happy to be back here. And last year, when I spoke to this group, it was the launch of the State of the World Children Report, where we had just announced the number of children that were missed due to the pandemic. And today we are also making this talk right at the launch of the World Immunization Week. We just did a few hours ago. And the World Immunization Week for this year is quite unique because the expanded program on immunization turns 50. It is the 50th year celebration and commemoration of the expanded program on immunization that has been quite instrumental in making vaccination available to children in the most hard-to-reach areas. So my talk today will be generally intending to give you an overall sense of what we have been able to achieve in global immunization, and of course to raise some of the issues that pertain to reaching the unreached children. And my dear friend Natasha will cover the content that relates to measles, which is an important flag and signal at this very moment, which is going to be an important topic to be discussed following this. If you can go to the next slide, I'll be very happy to start with a discussion about the 50 years history of immunization. And of course, history can be quite lengthy, but I will be quite brief in giving you a bit of idea of what actually happened over the past 50 years. This is a graph that shows you how immunization coverage has evolved, and it tracks the coverage of the third dose of vaccine against diphtheria, tetanus, and pertussis, and it shows how we have been able to make progress as global community over the past 50 years. So if you look at from the days around 1950, where UNICEF has been leading mass vaccination campaigns in the European continent right after the end of the World War II, you would see the global coverage of immunization has been quite low, in fact, less than 5% in those days. And right at the end, or once the effort to eradicate smallpox ramped up, this led to an establishment of a new program called the Expanded Program on Immunization. This is a program launched by the World Health Organization, but implemented in partnership with several other partner organizations. But if you see the first 5 years of EPI, despite its launch, there hasn't been much progress because it required so much energy to gather support and get a political commitment from countries. So in 1980, UNICEF launched a new program called the Child Survival and Development Revolution. And the intention was to really find solutions for major killers of children. And immunization was one of the most important interventions that was advocated in this. And as you can see, between 1980 and 1990, the overall immunization coverage across countries skyrocketed to around near 80%. Within UNICEF, we call this the Jim Grant effect. We had an executive director by then who's been able to push immunization across the world, who went around the world meeting heads of states, convincing them the importance of immunization, and even discussing with armed groups in areas where vaccination couldn't be provided to negotiate cessation of hostilities and armistice, etc., to be able to conduct immunization campaigns. This led to a program called the Universal Childhood Immunization, targeting 90% to get by 1990. Of course, we're still aiming 90%, but there has been significant progress. But there was a bit of stagnation and, of course, a slowing of progress from 1990 till 2000, until a point where the global community came together to launch the Global Alliance for Vaccine. That has been quite instrumental in pushing immunization coverage, but also increasing the number of vaccines available to countries from just first initial 6 antigens. Now we have 13 antigens provided by Gavi and around 20 plus antigens at this very moment that are specific to different regions. We are at a critical moment where we are celebrating the 50th anniversary of this important and impactful program. And of course, there were 3 strategy periods since 2000, which is the Global Immunization Vision and Strategy, and the Global Vaccine Action Plan, the one that just ended. And of course, 2 years ago, we started a new strategy, global strategy called Immunization Agenda 2030 that most of you already know. This is the history of immunization over the past 50 years. This program has been quite impactful, and you see it in the next slide that showed some of the astounding impacts of this program, which is not short of a miracle, we can say. So this program over the past 50 years has been able to save about 156 million lives. And this is a very conservative estimate and an excellent analysis done by our colleagues at WHO. And of course, out of these 156 million lives, 150 million were children, and about 100 million of them were infants. This equates to 1 child saved every 10 seconds for the past 50 years. 1 child saved every 10 seconds for the past 50 years. This is remarkable. And 55% of this was due to access to measles vaccination, that Natasha will speak much detail about this. And of course, 92 million deaths that were averted due to vaccination were a result of measles vaccination. And 42% of the reduction in infant mortality globally is attributable to immunization. And in fact, in continents like the African continent, this goes up to 50%, magnifying the role of immunization. In the next slide, you will see that this was not the only, this wasn't only the impact of immunization, but also several other programs. But immunization, the one before this, please. On top of this headline impact of immunization program, if you can go back a bit. Yes, this one. There were also several successes over the past, no, the one before this. And this includes, of course, the eradication of smallpox, one of the historical successes of humanity and human being, and the significant decrease in the number of measles incidents and measles cases. And so much innovation to reach the last mile has been able to be implemented, including innovations in cold chain equipments that has been able to, put vaccines in remote areas. And around 99.99% reduction of polio cases from just 125 countries to just 2 countries at this very moment that are endemic to wild polio virus. And of course, the neonatal tetanus elimination effort over the past decade has now resulted in a significant progress where out of the targeted 52 countries, some 40 have already been validated for eliminating maternal and neonatal tetanus. And this is a remarkable story. And if I ask each of you on this panel, you could tell me so many other stories on how impactful immunization has been. While the slides are wiggling, in the next slides, you will see the other impact of immunization in general. And it's an important thing to mention that immunization has also been quite impactful, not only in saving lives, but also really bringing in high return on investment. It's in the previous slide, apologies. And this high return on investment has shown us $1 invested on immunization can generate about $52 in return on investment. And of course, we know immunization and vaccines protect families from poverty by preventing catastrophic health expenditures. It's needless to mention, children who have been vaccinated have less days to miss from school, so it improves educational outcomes. And mothers and caretakers would spend more time in productive activities rather than taking kids to clinics when they are sick, which is also another impact of immunization in promoting gender equity. And above all, it promotes wider community-level herd immunity and, of course, reduces antimicrobial resistance. So if you have a tool that is actually impactful globally, vaccination and immunization would be the most prominent one. But of course, last year, and the year before, we had seen significant decline in immunization coverage as a result of the COVID-19 pandemic. The disruptions caused by the pandemic resulted in decline in coverage in so many countries. And is it on my side? But I see the slides vibrating a bit.
I think we're going to need to stop and reshare.
Maybe that might help a bit. Yes. Maybe it's the animation giving you a bit of a hard time. My apologies. Yeah, so just for the slide, yes, here. So in 2019, the overall global immunization coverage was about 90% of first dose of vaccine against diphtheria and tetanus and pertussis, and 86% against a third of this dose. But due to the disruption, these went down to 81% DTP3 coverage. But luckily, the results of the WHO-UNICEF joint estimate last year showed that in 2022, we have seen great signs of recovery. But while we celebrate the recovery, which was heavily concentrated in large countries, there remain so many countries that have not necessarily made improvements. And of course, it also leaves us with so many millions of children that remain unvaccinated that we need to catch up on. On the next slide, you see that over 86 million children have missed out entirely or partially on routine immunization if you factor the years 2019, 2020, 2021, and 2022. Out of these, about 62 million of them have missed all vaccines, and as we usually call them, the zero-dose children. And most of these children are in hard-to-reach settings. In the next slide, and as some of you may know, there is an effort trying to catch up on these children. But it's important to underline that the story of these unvaccinated children, and especially the zero-dose children, is one of underinvestment and inequities. It clearly paints the clear picture of inequity. Most of these children are in settings where there is so much underinvestment in primary healthcare, and most of these kids are in places affected by conflict, and the recent estimate shows about 40% of unimmunized children to be affected by conflict, or they are living in settings where there is conflict. And of course, poverty plays quite a bigger role, whereby over 1 in 5 children are zero dose in the poorest households. And of course, this is not comparable with the wealthiest one, which is 1 in 20. And we understand ethnicity plays quite a key role, especially in areas where there are specific groups that are not necessarily accessing vaccination for several reasons. Women empowerment plays quite a bigger role as mothers, as children that are mothered by women who are educated are likely to be more vaccinated. And so empowerment of women plays quite a critical role in making children access vaccination. Next slide. So the 80+ million children that remain unreached and who have actually been affected by increasing number of outbreaks had to be caught up, and the global community have come together to implement what we call the big catch-up. And the big catch-up has 3 major aims. One is to reach those children that were missed during 2019 and 2022. And of course, not only catching up on these children, but also recovering, or as we call the restore agenda, restoring immunization coverage, and making sure systems are strengthened so that we continue to reach the last child. Remember, I was telling you 1 out of 5 children still remain unreached, so which is an important aspect. So it is a program that is aimed at achieving these 3 important objectives. Currently, there is a very good progress. So many countries are already putting plans in place to roll out the catch-up campaigns, and the Global Alliance for Vaccine, its board have approved about $300 million to support countries with supplying 3 doses of vaccines. So many countries are planning in 2024 and 2025 to be able to implement this big catch-up. And we see some countries actually likely to be making a significant headways in 2024 and the rest in 2025. If we are not able to bridge this gap, this prevailing immunity gap, the likelihood of increasing outbreaks of diseases such as measles and diphtheria is quite imminent. And my friend Natasha will speak in much detail about that. I wanted to use this opportunity to also really thank all partners who are working towards stronger and resilient systems. And particularly, I would like to call out the government of Canada, who has been helping us as UNICEF to be able to deliver our promise in countries. Based on we had a recent funding received from the government of Canada in support of COVID-19 vaccination and strengthening systems. And it has really enabled us to support over 35 countries to strengthen their routine immunization and above all, to build stronger systems through supply and cold chain to the last mile. And of course, building of capacity of frontline health workers, which are quite instrumental to build trust and confidence in vaccines. And above all, mainstreaming of gender approaches to vaccination in primary healthcare service delivery. Social behavioral change interventions have been implemented in so many countries. And of course, support to public health emergency preparedness and response have been the prior focuses of this support and partnership with the government of Canada. Having said this, let me stop here and back to you, colleagues. Happy to take questions whenever the time comes.
Thank you so much, Dr. Lemango, for really providing that very succinct historical perspective on progress, but some of the setbacks and also some of the drivers of inequities that are, challenging, I think, very important collaborations in achieving that catch up on many immunizations. So we're going to hold the questions until after Natasha speaks. But Natasha, I'll turn it over to you now to provide your remarks. And just as a reminder, everyone, please use the Q&A function. And I'll be happy to take your questions after Natasha gives her presentation. Thanks again, Dr. Lemango, for those great remarks.
Thanks very much. Hard to follow that very expansive presentation. I hope you can see my slides okay. Yeah, great. Okay, so I'm going to be talking about measles and rubella because I can't speak about measles without speaking about rubella. I'm going to talk about some of the challenges we're facing, but also try and celebrate because this is the week we're celebrating immunization. So I don't want to be a complete downer with some of the things that I have to say about measles. So what I'm going to do is talk a bit about why measles and rubella are important right now. And if you don't read the papers, then you might not be aware. But if you do read the papers, you may have an idea already about why measles is important right now. Some of the achievements we can celebrate when it comes to measles and rubella, and then I'll take a peek into the future. So to start off with talking about measles and rubella are important right now, and the pictures I'm using here are from the Measles and Rubella Partnership. I forgot to say at the beginning that along with UNICEF, the WHO, CDC, and several other partner organizations are in a global group that is trying to push forward progress on measles and rubella. So these beautiful pictures are part of that global partnership. So why measles and rubella important? Well, measles is one of the most infectious viruses we are aware of in the world, certainly the most infectious vaccine preventable virus. And it causes a whole range of complications, including blindness and deafness and brain infection, diarrhea, pneumonia. I noticed that the CDC's recently reported on its recent measles cases, and nearly 40% of them were hospitalized. So when you hear the narrative about measles just being a childhood illness that everyone used to get as a child and it wasn't any big deal, that's just not true when you actually look what even happens in a country like the US, where it's a high-income country where children are generally healthy. So this can be a very severe infection, and it can cause death. Particularly in children with malnutrition and other health challenges. So now we're at a stage where around about 90% of countries in the world use measles and rubella vaccine together. So it's hard to split them up and not talk about both together. Rubella, which used to cause more than 100,000 cases of congenital rubella syndrome before vaccination started. It's the most common congenitally acquired infection, and So we're now moving forward in preventing this terrible disease, and we have to kind of think of these two diseases together because we're now giving the vaccines together. So it's not just about measles. The reason that the fact that measles is so infectious means we have to reach 95% coverage of 2 doses to prevent it. And that prevents measles very effectively, and now also rubella. But that vaccination has positive benefits beyond preventing measles itself. It actually protects other health investments because of some things that have more recently come to be understood. Measles causes this immune amnesia where the immune system forgets other diseases it had developed protection to. And this can put children at risk of other infections for weeks up to years. The other thing that measles does, it's made worse by malnutrition. So children with malnutrition get more severe measles, but measles causes diarrhea, which actually creates or causes malnutrition. So it has this double, being worse in children with malnutrition and causing it. We talk about it as being a tracer. Measles is a tracer. Ephrem mentioned this. It really shows up these areas where children are suffering in multiple ways, be it malnutrition or other causes of ill health, stress in communities that have missed out in various ways, who don't have access to vaccination or don't have access to healthcare. So we sometimes call it the equity virus because it shows up these areas of inequity. And if you draw a map of where the measles cases are, you'll find a whole host of other diseases that are going on, some vaccine preventable and some not. So it's really a marker for many things. And as Ephrem said, we have had challenges recently with immunization coverage falling during the pandemic. And the slide that he showed was for diphtheria, tetanus, and pertussis vaccination, but actually the falls for measles were even greater than the falls for diphtheria, tetanus, and pertussis. So we're looking at now being at 83% coverage globally, which is still 3% below where we were in 2019. And when you look at low-income countries, they've actually fallen even further and they're not recovering. So in the graph here, the top line on the left is, you can see the high-income countries in black and blue who, there has been a fall, but in the upper middle income countries, when you go down the World Bank classifications of countries down to the red line, which is low-income countries, they've actually experienced a 7% fall. They're 7% lower than 2019 with no real sign of improvement. And when you look at the economic picture, these countries are really facing the most significant backsliding in all sorts of ways economically. And the economic challenges are going beyond low-income countries. So we're now finding middle-income countries starting to have challenges buying their vaccines when they used to buy their own vaccines and not rely on help from other agencies. So we're currently in a really challenging situation globally, and looking at a very difficult year ahead of us. So with those falls in immunization coverage, it's not surprising that cases have been increasing. The number of cases reported to WHO in 2023 increased 84% compared to the year before. And looking at the numbers for 2024, we're already ahead of where we were this time last year. We're thinking this year is going to be worse. And with increases in malnutrition, we think this is going to be a bad year for increases in deaths as well. We have a metric we're using for the global strategy, the Immunization Agenda 2030, which is called large or disruptive outbreaks, it's defined as a country that has an incidence of more than 20 cases per million. And if you look at the number of those large or disruptive outbreaks, those increased from 32 to 52 in 2023, so between 2022 and 2023. What you see in the map is Europe and the Eastern Mediterranean WHO region sort of lighting up. So, Russia's went from being having very little measles to being blue on the lower map. And so you kind of see the increase in Europe and you see the increase in the Eastern Mediterranean, but you don't see such a big increase in the African region. And that's partly because the African region was already in trouble and already had lots of these outbreaks. So it's not that it was doing better, it's just that it was ahead of everyone else. So we're facing big challenges with these big outbreaks increasing, as well as the total number of cases going up. We're also, when we look forward to the end of this year, and this is using data that the CDC analyzes, looking at a combination of the coverage and whether or not countries have had campaigns to catch children up. And if you put all the data together, more than half of all the countries in the world will be at high risk of a measles outbreak by the end of this year. And half of those are low and middle income countries. And this adds up to a total of 142 million children susceptible to measles. And 3/4 of those are living in low and middle income countries, so at risk of multiple problems that will make measles worse for them. So right now, we're really, really concerned about what's going to happen, and we're hoping that countries, and I put the same picture that Ephrem showed of the big catch-up, we're hoping that countries will catch up. The big catch-up's going to, in its first approach, will reach a certain number of these children, but we need to do much more than that to reach all of these children with campaigns in countries that are not eligible for Gavi support, and we'll need to find the funding somewhere to reach children who were missed, and communities have been missed by immunization during the pandemic. The equity issue also really comes up when it comes to measles deaths for all the reasons I've already said. We have the deaths data. We have to estimate these because vital events registration data in most countries is not very high quality. So we estimate these using mathematical modeling, which means we're always about a year behind. So the data we have is from 2022, in which year deaths increased by 43% on the year before. And 92% of those deaths occurred in 24% of the world's population, which are people living in, children mainly living in the African region and the Eastern Mediterranean WHO region. So we're really seeing this focused inequity when it comes to deaths from measles. And because we've seen these cases go up, and because malnutrition is going up, we're anticipating the deaths when we get to estimate them in the coming months for 2023. Those are likely to have increased further on in 2022. So this growing inequity is of huge concern. And if there's one thing we could do in my heart to address the inequity, it would be to really address these deaths that are occurring, so that if we can't stop measles everywhere, at least we can stop children dying from measles with better access to healthcare and better access to immunization. So we're in a difficult situation right now, but we do have achievements we can celebrate nonetheless. And it's kind of remarkable. So it's a bit of a Jekyll and Hyde presentation, because we go from this, we're staring down the barrel of a gun in some countries, but in other countries there are these remarkable achievements being made. And I always like to say, whose life did you save by immunization? Because I'm hoping people who are on this call are probably mainly immunized, or at least pro-immunization, and immunize all their kids. And so I like to think you've all saved perhaps your own life, but perhaps somebody else's life, and that's an amazing thing. A measles vaccine saved an estimated 57 million lives worldwide between 2000 and 2022. And the global goal that we have in our strategy is to save 50 million lives in the decade of this current global immunization strategy that I mentioned before, i.e. 2030. And that goal can't be met without measles vaccine, because measles vaccine alone accounts for nearly 40% of the lives saved by vaccines if you project forward over this decade. And in fact, looking backwards, and Ephrem already mentioned these numbers, for some reason mine are slightly different, and I'm not sure why, but these are the numbers I have of 154 million lives saved since 1974. But the same proportion, that 60% of these lives saved are due to measles vaccination. So if you look back to 1974, we really have a situation where measles vaccine can be credited with actually the majority of the lives saved by this incredible program, the expanded program, what used to be called the expanded program of immunization, which we're now calling the essential program of immunization. So it's a remarkable achievement that is quite overwhelming when you think of all those people growing up and having healthy, happy lives with no idea that they're there because they had a vaccine when they were a child, or someone else had a vaccine when they were a child, and that's why they're able to just get on with their lives and not think twice about it. Countries are making steady progress towards elimination of measles and rubella and congenital rubella syndrome. So right now we have 51% of all the countries in the world are verified as having eliminated rubella. They're verified by an independent committee. 90% of all the countries in the world have rubella vaccine, and the last cases of congenital rubella syndrome are predominantly happening in the 19 countries without rubella vaccine right now. 3 of those countries have plans to introduce or in the process of introducing, but there are still 16 countries that need to introduce rubella vaccine. So we're working hard to get that final push completed. And 43% of countries currently verified as measles eliminated. And with measles, it's a bit more, 3 steps forward and 2 steps back. Some countries lose their status and then they regain it. So it's harder to sustain measles elimination, whereas rubella really seems to be very robust. Whatever goes on at the moment, it keeps countries that achieve it seem to sustain it. Interestingly, India and China, they're really on their way towards eliminating measles. And once India and China have eliminated measles, we will have half of the whole population of the world, or possibly more than that by then, living in an elimination setting. So we've got, and China and India are close. So we've got some good news to come if we just keep on track in the direction we're going. So I just wanted to finish up now. My last slide, we're just trying to imagine what the world might look like in 50 years' time. So what's that, 2074, we're going to, maybe that's hard to imagine for some of you. But think, we've been talking a lot about what we've achieved in the last 50 years. So why not? 50 years ago, people were thinking, what could we do? What can we do with these vaccines? And here we are 50 years later, living in a world that's benefited from that vision at that time. So where do we go from here now, looking forward to the next 50 years? And let's imagine a world in which measles and rubella have been eradicated. And I think, soon we will be halfway there. So it's not inconceivable. And imagine a world, we haven't mentioned the word smallpox on this call because we don't have to, it's been eradicated. So imagine this webinar happening, if webinars still exist in 50 years' time, where we're not talking about measles and rubella because that's something that is in the history books. And then coming a bit closer to what is going to happen soon, imagine a world in which vaccines are given as patches, where you can just slap on a patch and a child will be protected. And here's a picture of a child in a clinical trial in the Gambia last year, a phase 2 clinical trial for a new measles rubella vaccine that is given with a patch that's put on the child for 5 minutes, and then they get, at the moment, what looks like just as good protection as they would get from a needle and syringe, can be given to the child by anyone, has fewer cold chain requirements, and could actually revolutionize the way we deliver these programs. So, we have amazing things coming down the pipeline that will make the world look a very different place in 50 years' time. And we can choose what our future looks like. And to borrow from the EPI at 50 celebration motto, we can choose what the future will look like, and this is humanly possible. So I wanted to finish there and thank you for your attention. I'm very happy, like Ephrem, to take any questions anyone may have. Thanks.
Thank you so much, Natasha, and thanks for ending on that hopeful note and also aspirational and visionary note. I think it was a very apropos. So just very briefly, just to introduce myself, I'm Erica DiRuggiero, and I'm a colleague of Shelley's and Natasha as well, who's an adjunct professor at the Dalla School of Public Health. I direct the Center for Global Health, and it's really my great pleasure to now moderate this session. So for those of you who haven't had a chance to submit your questions, please do so. But I'm going to start off with a few that have already been submitted. So, and I'll just invite either of you to jump in. And so the first question is that we saw in the COVID-19 pandemic how science communication has failed in many ways. For example, how many people in North America feel a lack of trust in scientific institutions and also feel their right to their bodily autonomy. that they claim was violated by the political approach taken by many countries to increase vaccinations. So one of our participants would like to hear, and I think both of you would likely have comments on this. What have we learned from the pandemic in terms of both scientific communication and political strategies for increasing participation in vaccination programs? So, Ephrem, can I start with you? Because I think this question was actually dropped while you were talking, so I'll give you the first go at it.
Yes, thank you so much, Erica. This is an important question, and it touches on to two important points. One is the overall vaccine acceptance space and vaccine hesitancy. And another aspect of this is, it's another spectrum, is whether mandatory vaccinations or vaccinations that pressure people, programs that encourage people to take vaccination work or not. What we have seen during the pandemic, in fact, is the value of communicating things very well. And there has been so much communication, there has been so much source of information. And of course, given it's a pandemic setting, every information is useful, and the likelihood of every information to be twisted is quite high. So it was quite a struggle for people to be able to sieve through what is available on media and to be able to pick the one that's actually useful. And what we have seen, in fact, one of the analysis we did during the State of the World Children report was to look into whether vaccine hesitance or confidence on vaccine have went down due to the pandemic. And there has been so much over awareness and, of course, so much information available related to COVID-19 and the vaccination and the way the vaccination is made, that we have seen a decline in over 40 countries, a slight decline up to a significant decline in the overall perception of whether vaccines are good at saving lives or not, or whether would they recommend their kids to have vaccination or not. So this is, vaccine confidence is quite volatile and does require us to continuously monitor the state of affairs, but it does show that we have to keep an eye. But we have seen also in subsequent years an overall improvement of vaccine confidence right after the pandemic. So it's important to keep in mind vaccine hesitance is usually born out of an overall mistrust or lack of trust of the systems that deliver the vaccines, of the governments that avail the vaccines, mistrust of or lack of trust of the manufacturers that produce the vaccines, that spur down and somehow percolates into overall vaccine hesitancy. So I think what we have seen in the pandemic is the global effort to be able to avail vaccines in such a short time has been received both positively and, of course, partly negatively, given that it was quite unconventional for vaccines to be ready this time. So many people may have thought, procedures may have been cut down, accelerated, etc., and may have shown some sort of safety concerns. But we have seen vaccines actually saved the world. That is how we came out of the pandemic. So we can firmly say, while we talk about 50 years of success, the most recent success that actually averted, kind of brought back the world back to its life, is actually vaccine. So I think the scientific communication have been there. Maybe it has been a bit hazed by non-scientific and, of course, twisted ideas as well. Mandatory vaccination is an area that has always been contentious. But what we know is there are countries who achieved higher coverage with mandatory vaccination, countries like the US. And there are countries who achieved higher coverage without mandatory vaccination, the likes of UK, etc. So it is important to keep in mind the most underlying part, whether you make a vaccination mandatory or not, is whether you have the systems to deliver, and at the same time, you have built the trust that is able to encourage people to take the vaccines. And there are several reasons that push mandatory vaccination, which could warrant another webinar on itself.
Yes, so very true. But I'm really glad you brought in sort of the political economy, right, related to the distribution of any mass campaign like that. Natasha, did you have anything to add on this question? Otherwise, I can also move to another one.
I may support everything Ephrem said. I think we do need. I think one thing we probably underestimate is the need for scientific independence, and I've experienced working in organizations that were established to provide an independent scientific voice, and that were gradually sort of shut down by government and not allowed to speak out. And I think that doesn't help with public trust if government is too controlling. I think it also helps when when politicians and scientists can work more closely together, and scientists need to learn how to communicate with politicians and understand where they're coming from. So I think that's really important as well. But probably the two things really are like understanding where communities are coming from and listening to them, so that you understand what the limit, what people will accept and what they need to hear to understand what's going on, and having those, as Ephrem said, those really good health systems, because a lot of you can have somebody who's worried, but if they go and they go to find out about vaccination, they get a warm welcome from somebody who greets them with a smile, answers all their questions, and is sympathetic and listening. They are much more likely to say, okay, great, because healthcare providers are the most trusted sources of information. They're much more likely to say, yes, great, thank you, I'll go ahead with this, than if they go to an underfunded system where people are harassed and overworked and just want to get through the day. So I think there's lots we can do.
Yeah, absolutely. And I think it's also really forced us to really think about trust, right? And the distrust, mistrust, and the historical systemic sort of effects of health organizations before they became stewards of, the COVID-19 vaccine. So I'm going to ask two questions, and then I think I think the first one might be more for you, Ephrem, because the second one's specifically on measles, but I'm sure you can comment as well. So I'm going to throw both questions out just in the interest of time and getting more questions on the table. So the first one is, one of our participants mentions that they come from a developing country and have a better understanding of the factors leading to hesitancy in developing nations, but are interested in understanding how these factors are different in developed nations. So whoever would like to comment on that. And then the second one was about, could you briefly share the challenges to maintaining measles elimination status? So maybe Natasha, I'll start with that first one around measles, any of the challenges, and then we can come back to the other question.
Sure. I think that the major challenge for maintaining measles immunization elimination is the fact that you need that such high coverage, the 95% coverage that needs to be sustained. It's easier to reach it once, but then maintaining that level is very difficult, because it's the public health paradox that Jeffrey Rohn spoke about years ago, of how once you've prevented something, everyone forgets that it's important. So if a country where measles goes away, it's no longer a political issue, there aren't outbreaks, then people forget why they needed it. And so that's the hard piece of it. You need really good systems, and you need good data systems. I mean, it's a tracer of a good immunization system overall, that you've got good data and good delivery, and you're reaching children equitably. You haven't missed out any major groups that are going to have outbreaks. So that's what, but some countries have had issues with cold chain, but there's been historic issues with, seems to be in some countries, they've had a historic issue with a cold chain issue, and then they get outbreaks in older kids that can only really be explained by that. That's happened. Sometimes it's a vaccine hesitancy issue, like we saw in the UK, where the Wakefield effect, when measles came back following a big fall in confidence. So that requires a different approach. It does vary a bit from country to country, but the basics are, you just need a really good access to primary care for all children, and really good surveillance systems to track what's going on and know who's been vaccinated, and if outbreaks do occur, you can respond quickly and stop them happening.
And as both of you have made the case for long-term investment in both of those going in the same direction. Any thoughts about the other question, Ephrem, around perhaps contrast
let me
and
just
hesitancy?
comment on Yes. So happy to reflect on vaccine hesitancy and the integration issue, whether immunization versus other programs. The causes of vaccine hesitance vary from place to place, but they are not unique to a particular setting. You cannot say, oh, low-income settings, these are the causes, and high-income settings these are the causes. But what we have seen in all this is it is good to treat this vaccine confidence and hesitance issue as a spectrum, whereby you see there are people who are ready to be vaccinated, regardless of whatever is happening around. So they will find a way. So this is one end of this spectrum. And of course, some people are hesitant, which means they may need some information to be convinced. And it does require either the health worker to let them know of some of the specifics and address their questions. You would also find people who are vaccine resistant who would say, no, I'm not going to have my kid vaccinated. And if you go to the other end of this spectrum, you'll find people who speak against vaccination. So they are vaccine opponents or anti-vax. So it is sometimes people say they usually see vaccine hesitancy equals to anti-vax, but not. In fact, most of the parents, and the recent research we have done in the Eastern and Southern Africa region shows that 98% of parents wishes to have their kids vaccinated, period. But our immunization coverage is about 83, 84%. And in fact, in that side, it's actually a little less. So it shows you that before even talking about this major challenge of vaccine hesitance, there is already available demand that we are not meeting, which is affected by access to vaccine. So part of this overall hesitance and vaccine demand and vaccine confidence is actually access to the service itself. Imagine a mother that has to walk 2 to 3 hours to have her child vaccinated. And when she arrives at the health facility, she ends up knowing that there is no vaccine, or it's not available, or it has stocked out. It is unlikely this mother will go back. So this mother will be labeled either vaccine hesitant or she does not want vaccine, etc., despite her effort. And of course, I have had a chance to travel to different districts in different countries, and I ask why they don't want their kids to be vaccinated, those who might be a bit hesitant. And most mothers say, my child has a fever, my child will be sick, will be ill, etc., after the vaccine. And they would say, no one has informed me about these side effects of vaccines before they give me. So it's that specific thing that earlier Natasha raised, that the health worker takes an extra mile of explaining, expect this and take this paracetamol for the child if the child has fever. So these simple measures would actually improve the overall confidence on vaccine in general. But of course, it's important to keep in mind there are some significant players who impede access to vaccines or who spur anti-vax sentiments. Could be religious leaders in some countries. It could be just community leaders. And in COVID-19, we have seen even health workers were resistant to vaccination. So no one would come and take vaccine from a hesitant or resistant vaccine or health worker. And in some places, this has been fueled by social media. There are so many middle-income countries where internet is Facebook. So basically, everything comes out of Facebook. And in that setting, it's very hard to filter the right from the wrong or the accurate from the inaccurate. So those are the kinds of dilemmas that you see between different countries, but you could find all this in one country. And that is why it's important to engage communities, to understand what are the social issues that communities are raising. If there are rumors, you need to really diagnose those and respond to those rumors as any health worker or any district manager will need to be able to do. That's why we promote social listening programs and, of course, designing of immunization service delivery programs to be able to be much more amenable to the needs of communities in terms of opening hours. In urban areas, if a family has to cut down their working hours or have to forfeit working at a particular setting to have access to vaccine, that's a different story. So expanding opening hours, opening during weekends, doing moonlighting, etc., is quite helpful, or getting it closer to this specific settings what will be quite important. And finally, immunization is usually seen as a vertical program. It is This is a personal opinion. It is the immunization program has been managed vertically. It's not a vertical program, but it has been managed vertically. And of course, it's one of the most impactful interventions that we have that can be easily delivered in settings that are primed to be able to deliver that. But the way funds are provided for immunization and vaccination over the past, several years and decades can easily make it look like immunization is a vertical program and money goes to immunization. There are health workers for immunization. There are programs for immunization. There are facilities for immunization, and so on and so on. But of course, it's good to keep in mind as well, immunization has been used as a platform to give more services. Several immunization campaigns do carry nutrition services with them, vitamin E supplementation, deworming, growth monitoring of children, etc. So the actual practice is child-focused practice rather than just immunization-focused practice. So immunization does offer the chance to reach more children with different set of interventions, as is the other interventions who provide such opportunity.
Yeah. I think, Natasha, you and I have talked about this before around this sort of the vertical versus horizontal health system strengthening and thinking about immunization as a more of a diagonal kind of approach. And, Ephrem, I think you've anticipated the next question, and I'll turn it to Natasha if you have some other thoughts. But the other participant asked, one of the benefits of immunization mentioned is health system strengthening. So what is the potential of more integration of services, including immunization with other services, for example, those that prevent malnutrition, in the spirit of also improving trust? So this idea of, bundling different interventions, so immunization being one of them. Natasha, can I maybe turn it to you to see if you have some thoughts on that? Thanks.
Yeah, sure. There's huge opportunity to do that, and we currently do on the measles side. We try and make sure that vitamin A and measles vaccine are bundled together where that's relevant, and try and bundle different vaccines together. But there's also an opportunity in in appropriate settings to include malaria bed nets, nutritional advice, a whole range of things, and that's why I think, as everyone was saying, it's part of essential primary care. This immunization is it's a key part of it, but it really shouldn't be seen as separate. And it's funny, for some reason I was thinking about my own kids who were born in the UK, and when I went to take them for their immunizations, I went to the community pediatric clinic where I got nutritional advice, breastfeeding advice, I got developmental advice, I got other mums hanging around saying, oh, what do you just handing out advice, whether you wanted it or not. So it was a very integrated system, and I think, and it was, and then we saw the community pediatrician who did the immunization. So I agree with Ephrem. It's like, it isn't a vertical, it shouldn't be a vertical program. It should just be seen as a key pillar that strengthens the whole of primary care.
And Erica, I think it's also important to state that immunization investments have been used to strengthen systems and are also currently being used to strengthen systems.
Okay.
So it is basically, what it means is you have a dollar financed by any immunization donor or immunization focused donor that comes to a country to train a health worker. And health worker training is part of the system strengthening. And of course, you build a very good supply chain system that is able to take vaccines from the national stock level to the national warehouse to the district level. And the same system is used to transport malaria commodities or etc. as you wish. And the information system that we have invested a lot through immunization money is used to capture data of other interests of the countries. So it is safe to assume that immunization investments are actually being used. And in fact, significant COVID-19, one of the blessings in disguise in COVID-19 investment has been, actually the funding has been used to strengthen systems in countries. That may have otherwise have not been done, would have not been done. Had it not been for investment made as a result of the pandemic. So we can safely assume that immunization investments do strengthen systems. Could we do better? Could we align different verticals of different fundings to bring together aligned on a one country plan that is able to implement programs based on their priorities, etc.? Yes, we can. For now, we are where we are at this moment, but the future seems to be going towards that. There is so much call to bring different funding platforms together to at least speak to each other in aligning programs to supporting countries.
Yeah, and I think as you both nicely illustrated, that alignment between surveillance, strengthening health systems, also measuring co-benefits, right? And Natasha, you talked about the co-benefits for nutritional status, but also co-benefits for system building are, I think, really important to communicate and relate back to immunization. So I'm going to turn it back to Shelley because we have about a minute left. But thanks so much for engaging in these questions.
Thank you, Erica. We wanted to thank all of our attendees to making time to join our webinar this afternoon, and a huge final thank you to our panelists for the really engaging and thought-provoking talk. We hope to see all of you at our events in the future. Thanks so much and have a great afternoon.